All right, pathophysiology of ventilation and respiratory emergencies. We're going to talk tonight about how we breathe, why we breathe, what makes us breathe, how it works on different levels, and some pathophysiology, some of the sicknesses and diseases that are associated with it. Okay, so that is what we want to do tonight. This picture is not particularly clear, oh, I thought I had a clearer one. Okay, this is review. We have done the anatomy of the respiratory system. I will just mention a few things again for clarity. Air enters into a human via the nose and the mouth. Space behind the nose is called the nasopharynx. Space behind the mouth is called the oropharynx. Then below that is the pharynx. And then we have something called the epiglottis. The epiglottis has a job to prevent any foreign bodies from entering into the trachea. That is the job of the epiglottis. After that, we were in an area called the larynx. In the larynx, we've already discussed this, are housed the vocal cords. These are all things that you need to know in EMT school. Below the vocal cords is this straight pipe here. It's called the trachea. And the trachea bifurcates, which means splits into two. Okay? Splits into two. And these are the main bronchi. So you have one pipe that splits into two. The place where it splits is known as the carina. And it splits into two main bronchi. From the main bronchi, it will now split off into many, many smaller bronchioles. Alright, so all these smaller pipes are known as bronchioles, and they all come off of the two main left and right bronchi.
What's the splitting place called?
The carina. Not something you'll probably be tested on. Okay? At the end of every bronchi, you have these grape-looking sacs, bunch of grapes looking, okay? And these are known as the alveoli. We've discussed these already. We know what they are. We'll talk about it a little bit more. These are the alveoli. This is where the gas exchange is going to take place. The alveoli are in close proximity to the pulmonary capillaries. Alright, so these are all words that you got to know. These are in the other book with the circulatory system, where I mentioned the alveoli and the pulmonary capillaries. Remember, what is a capillary? We did this last time, so we should know. Capillary is a very small, thin, how thin? 1 cell thick blood vessel that allows for diffusion, allows gases to walk through the cell wall. Okay, that's called diffusion. A gas can leave and a gas can enter. So in the alveoli, we are bringing in oxygen from outside, from the ambient air. 21% of air is oxygen. We breathe that in. That will go into the alveoli, and that will then get transferred to the pulmonary capillaries, right, into the bloodstream. The opposite effect is also happening simultaneously from the pulmonary capillaries. We are bringing into the alveoli the waste product of human metabolism, which is carbon dioxide, and that will in turn be exhaled. Okay, so inhale to breathe in, exhale to breathe out. Below the lungs is this dome-shaped muscle, and that is known as the diaphragm. We will talk more about that and how it works in a few minutes. So, on this slide, I broke it up a little bit into upper and lower airway. It's something that's very important because when we do look at pathophysiology, it's something we're going to want to know. Is this an upper airway disease, or is this a lower airway disease or problem? So you've really got to know. According to this, or at least according to me, the larynx is the bottom of the upper airway. Now, I was reading somewhere over the weekend about how maybe the larynx is the beginning of the lower as opposed to the end of the upper. I think it's up for discussion. I think that, many medical textbooks and literature may show different ways. For now, we're just going to leave it that the upper airway ends at the larynx.
In the slide you showed previously, it was part of the upper.
Yeah, and I've still got it. Yeah. So we're gonna stay with that opinion, okay? Lower airway would be the trachea, right, which is this large pipe over here, and the bronchi, the bronchioles, and the alveoli. All right. Remember why the pulmonary capillaries are not mentioned here? Because they are really part of the circulatory system. Remember, their blood supply. This is really only has to do with getting air in and out. Okay?
There, it's under supporting ventilation.
Yeah. So supporting ventilation, helping us in our breathing, we have the chest wall. That would be the muscles between the ribs, known as the intercostal muscles. Those are part of the chest wall. The pleura, anybody remember who that is?
Sac around the lungs.
Very good. The diaphragm, that's the large muscle over here, which we're going to speak about. Intercostal muscles, again, intercostal, costal. Anything in medicine uses the word costal is talking about the ribs. So, intercostal, between the ribs. The phrenic nerve, I don't really talk about that much. The phrenic nerve is not part of the circulatory system, and it's not part of the respiratory system. It's part of the nervous system, right? And the phrenic nerve is the brain's way of talking to the diaphragm. Okay, so just keep it very simple. And here you go, here are your pulmonary capillaries, all right? So everything got to mention, this is what we need. All right, good. Three definitions that I do expect you to know and understand the difference between, all right? So what's a ventilation? Okay, what is ventilation? Well, ventilation just means getting air in and getting air out. Okay, it's that simple. Getting air in and getting air out. That's ventilation. All right, remember, getting air in, a word it can be used for is inspiration or inhalation. They all mean the same thing. Getting air out is expiration or exhalation. All good. Any way you want to cut it. All good. Okay? So that's ventilation. Next word I want you to know is oxygenation. Oxygenation is bringing on board more oxygen into the bloodstream. Okay? Getting more oxygen into the bloodstream. Last night you got to see oxygen tanks, right? You also got to see the BVM. Okay? So with a BVM, we can physically ventilate a patient. With an oxygen tank, we can oxygenate a patient. This one we can't do. All right? This is respiration. And respiration means that we need to have gas exchange in the alveoli and the pulmonary capillaries. We cannot artificially force that to happen in emergency medicine in the field. Okay?
What's a respirator?
It's not in the field.
Right.
Artificially done, not right.
Okay?
So the act of respiration is the diffusion.
Yeah. Yeah, it's causing that diffusion to happen. Okay? Causing the gases to change. Okay?
So oxygenation isn't respiration.
Right. That's providing more oxygen into the bloodstream.
And that we could do?
Sure, we give them more oxygen.
How do you know it's getting to the
So
bloodstream?
technically you can only do one way. You can only do the one way of the oxygenation. But that reverse effect
Right.
of bringing
Has to
of
happen
bringing
on
the,
its
the
own.
carbon dioxide
Has
back
to happen
into, means
by the metabolism of the body. Okay? Alright, so let's look at each thing now. Let's break breathing apart, and let's look at this, which is my little physics experiment over here. Alright, so we'll keep it really simple. When the box is smaller, are there more collisions or less collisions?
More.
More. Okay? So what that tells you is that when there's a smaller space, there will be greater pressure. And in physics, pressure is inversely proportional to area. Which means, alright, I went too deep, which means as area gets smaller, pressure gets
Stronger.
greater. That's all. That's all. Okay? So exhalation or expiration, the diaphragm relaxes, okay? The chest contracts, and pressure increases. Why does pressure increase?
Less space.
Because the lungs are deflated, so there's less
The
space.
chest or lung?
Okay? This is talking about the chest. Okay?
The whole chest cavity is compressing, is contracting, so there's less space.
So there's less space.
The diaphragm's going up.
Right. Diaphragm's going to be like this. So that's going to force.
The diaphragm moves because you breathe?
Well, it moves based
you're
on lots of different
Voluntary.
reasons. Okay. Well, we'll talk about that in a minute. Okay. There's less space. Look. So there's more pressure. Okay. So there's more pressure inside than outside. Which direction is air going to flow? Gases move from areas of
Higher or lower.
higher to low, right? So that's why when the chest contracts, there's less space, and you're going to
exhale.
breathe out. Okay? Inspiration, how do we breathe in? Well, it's the opposite. Okay, the diaphragm contracts, which means it gets pulled down. Okay? The chest expands, so let me show you. So here, if you pull down from here, straight down, where will there be more space now in the thoracic cavity? When it's up there, or when you pull it down?
Pull it down.
When it's pulled down, there'll be more space. Okay, more space, less pressure inside, more pressure outside, and air will get in, come in.
Right.
Come in. Alright, remember atmospheric pressure is about 760 millimeters of mercury. We're talking about very small amounts of change. We're not talking about going from 760 to 400. We're talking about maybe 10 millimeters of mercury. Tiny amounts of change. But it's enough to cause this to happen. Alright, here's a good, watch this. Watch the diaphragm. Okay?
Ellie didn't do this one.
Yeah, way too sophisticated.
Watch the diaphragm, see it gets pulled down, and the chest gets larger. See?
When are you breathing in and breathing out?
That's just showing you the
That's
diaphragm.
Exhale.
The
Moving up
natural
and
state
down.
of the diaphragm is to be expanded.
Diaphragm comes
Is that
up. When
correct?
you inhale, diaphragm comes down.
It's a
Natural.
relaxed mode.
Relaxed is when it's up. Yeah.
That's where the,
Yeah.
the confusion. The
Yeah.
relaxed is when it's
Yeah.
up and it's being pulled
Pulled
down.
down, okay, that causes more space
Right.
inside, less pressure, makes you breathe in.
Right.
Alright, we're gonna talk about it more. So we spoke about spinal injury, head and spinal injury. So you can remember that C3, 4, and 5 keep you alive. Alright, that's like a little rhyme there for remembering these are the things that make you breathe. Alright? Again, people that get C1, 2, 3, 4, 5 injuries don't usually survive. If they survive, they'll probably be quadriplegic.
So
Okay?
the C4 and 5, they're the ones that control the thorax.
Yeah, 3, 4, and 5 control the breathing. Alright? Now, have I spoken about hypoxic drive already?
No, you
Yeah, that's
mentioned
the one
it.
that kicks in
You
when
mentioned
the, what's it called?
Very good. So I
Backup
did.
drive.
Alright, let's just run through it again quickly. Healthy people. Why do healthy people breathe?
Low pressure, high pressure.
Oh,
No. Why do
The brain
healthy
tells them to
people
breathe.
breathe?
The brain tells them to breathe.
Okay, why does the brain tell you to breathe?
It
Why?
needs oxygen.
No, that's not why healthy people breathe. I did discuss this. Nobody?
Gee.
Healthy people breathe because the brain is monitoring the levels of
CO2.
CO2. Do remember, good. The brain is constantly monitoring levels of CO2. There are chemoreceptors in the arterial blood supply. Where are they?
It's in the fluid.
Where are the chemoreceptors?
In the arteries.
In the arteries. I just said it. Okay. The brain is constantly monitoring how much CO2 there is. CO2 has to be at a very specific number. If it gets too much, the brain realizes that, sees that, and decides to breathe, right, to get rid of it, and therefore bring in more oxygen. This is why healthy people breathe. Okay, it's not to do with oxygen. There will be questions on this type of thing. All right, so you got to know this.
On the quiz or the test?
On the state exam.
Now, people who are not so healthy, that have lung diseases, and we'll talk about them tonight, may have switched over from the normal stimulus to breathe to something called hypoxic drive. All right? Now, the word hypoxic we need to understand. The word hypoxic is made up of two words, hypo, which means low, and oxygen. All right? So hypoxic just means low level of oxygen. Now, again, these are people with certain respiratory disease that we'll talk about soon. However, you need to understand that regular, normal, healthy people do not breathe using the hypoxic drive. Okay? Regular, healthy people breathe based on CO2 levels. Okay? We'll talk about who is possibly going to breathe using hypoxic drive later on. Okay? So what happens is the CO2 levels get so high that the brain just can't fathom what's going on. Just gets higher and higher, and they just keep retaining these crazy high levels of CO2. At some point, the brain says, okay, forget that monitoring system, I got a backup. Okay, and the backup is, let me see the oxygen. Oh, the oxygen's really low? Okay, I'll tell the body to breathe. All right, but it's a backup system.
Does this have any ramifications in the field?
So it's a very good question. If it used to, many years ago, there was the idea that if you gave oxygen to a patient who was breathing using hypoxic drive, they may stop breathing. That's what we thought. Turns out it takes hours and hours, maybe days, for you to give them enough oxygen for their brain to decide to stop breathing based on hypoxic drive.
Which it can't do.
Well,
Which it can't do.
Eventually it will, he's saying.
eventually, but it takes hours and hours. You'll never be with the patient long enough. So now they do ask this question. They'll give you a case of a patient who may be breathing using hypoxic drive, and they'll ask you, how will you treat that patient? And the answer is, with oxygen, just like any other regular patient.
How do you know if a person
Right, that's a good question. That's a whole separate question. They
have
told
reported
you.
lung disease?
Huh?
They told you.
How do they know?
They have reported
Their
lung
doctor
disease.
told them.
They're gonna use
That's
something
what
else.
I'm getting at. How do you know what part of
You
the brain?
won't know.
It's different.
Based
All
on
it is a different part of the
You
brain.
can't know because you can't test the levels of CO2.
Oh, so over a certain level CO2,
You know
it
that the
means that the
hypoxic drive
hypoxic drive is activated.
Maybe activated.
Maybe activated.
Okay? So again, how it affects you in the field, the
Almost
reason we
never.
teach it is so that it shouldn't affect your treatment in the field. Okay? What they do in the hospital, that's a whole different ballgame. But you have a patient that's having difficulty breathing, then you give them oxygen. Okay? No matter what you read in the books or, the books from 30 years ago. Okay? Okay, so this is what I said. Okay? Chemoreceptors measure levels of O2, CO2, and they keep track of what's going on.
That's the ulterior blood supply? You mentioned something?
What?
When you were talking about chemoreceptors last time, you were talking about some...
Arterial blood supply in the carotid arteries. Okay? The stimulus to breathe is controlled by the medulla oblongata. That's not really something you need to know. That's fine. Alright, let's talk about VQ mismatch. This is quite a complex topic of medicine, and I'm not going to do it justice tonight, or just give it to you very, very simply. V stands for ventilation. Q stands for perfusion. Right? Because the word perfusion begins with a Q. Right, good. I'm glad you all agree. So it's called VQ mismatch. Basically, to make it really simple, it means either one of two things. Either you've got good blood supply going to the lungs, but no oxygen getting in to hop on board. That's one possible problem. The other problem with VQ could be the opposite. You've got a poor oxygen, you've got poor blood supply getting to the lungs because of bleeding, shock, or whatever it may be. But you've got great oxygen coming into the lungs. So when one of these is off, it causes this VQ ratio mismatch. It's quite complex. You know, we can spend hours on it.
Isn't that what the brain though?
What?
Isn't that one of the reasons the brain doesn't regulate that?
The brain, sometimes it can't. If you're bleeding out and there's not enough blood getting to the pulmonary capillaries for whatever reason, but you're still breathing just fine. So, again, I can't spend enough time on
Yeah, that's
VQ.
not good.
It's really complex. Okay? It's in your curriculum. I mention it.
It's not gonna be on the test. So.
Right.
But this is the thing, it doesn't last long. Because eventually, because of the
They
load.
go
One way or another.
one way or
One
another,
way or
right?
another, it
But if you can diagnose it in the field,
Then go to medical school.
then you know,
Save it.
then you can save a life, right? Not that you can diagnose it, but at least to think about it that
You
it's
do
a
that,
possibility.
Then what? What would you do?
Then,
You may be able to.
Anyways, you're giving them oxygen. Like,
right,
what would you do?
not much more.
But
Rule of
drive a
thumb,
little
give oxygen.
quicker.
Right. Okay, these are the things that are on your. One of the most difficult things in medical school, you ask anybody that did any sort of real medicine, is called the Krebs cycle. Okay, it drives everybody insane. Okay, so you don't have to learn it. You don't really even have to know about it. Okay, you want to see how complex it is? You know, you can Google it. It's horrible. Okay, every medical school student, this is their nightmare.
What is it called?
The test, the Krebs cycle. Basically, it's how ATP gets produced in the body. Now, ATP is the energy that the cells create in order to do their thing, to do what they do. All right? It's called ATP, adenosine triphosphate. You don't have to worry about it, but it needs to be mentioned. I want you to know the difference between aerobic and anaerobic metabolism. I'm sure I spoke about it already. Aerobic metabolism is good metabolism that is done using oxygen. Everything's functioning properly. Anaerobic metabolism is where the body is functioning but not with enough oxygen, and that causes a waste byproduct called lactic acid. Now, your patients who go septic or get into septic shock typically have a very high level of lactic acid. Why do they have lactic acid? Because they are not metabolizing properly with enough oxygen. They are sick. They are septic. They're in septic shock. And there's a direct link to low levels of CO2 in the body, high levels of lactic acid, and fever. And these people are typically, these are going to be your patients that are in septic shock.
Don't muscles build up lactic acid when there's too much CO2?
You're talking about like when athletes
Correct.
train and all this sort of
So when
stuff.
there's too much CO2,
Right,
they can't
but-
get rid of it fast enough, the lactic acid builds up.
Right, so they're not sick. It's different.
Okay.
Okay? These,
So what's
this is anaerobic metabolism. Now I know that there are certain athletes that want to increase levels of lactic acid.
Well, lactic acid tolerance.
Yeah,
They want to be able to increase the level at which they can perform with the lactic
with the
acid.
lactic
there.
acid, yeah. I know, it's very, I don't really understand how
That's where the
how that
ATP
works.
that's where all these studies are. How can you get somebody to increase performance even with the lactic acid?
Uh-huh. So that's what
That's
the,
why athletes do artificial oxygenation of their blood, so that they can
go,
perform at that level, and then their blood is artificially oxygenated instead of just breathing in. Their blood has natural oxygen in it
Wow.
already.
okay.
They,
Is it, is it
How-
on the
I think
sideline? Is it-
how-
no, they do blood
presentation
transfusions. They
Oh, yeah.
they give blood for months before, and then they put their blood through a machine that oxygenates it, and then they do a blood transfusion back of their own blood, but with a higher oxygenation level. So then when they perform, there's no drugs in their
Sounds like
systems. They don't get caught,
PowerPoint
but they're just
presentation next week.
artificially higher oxygen in their blood, so they can perform
Let's bring his bike in next week.
higher levels of lactic acid.
That has nothing to do with the guy standing on the sidelines with the oxygen.
What?
No.
What's what?
Banana tripping.
That has to do with like,
Orange juice.
yeah, lemons and things.
Nothing to do with the crabs?
All right, so I know that athletes and the such have this whole thing with measuring lactic acid and trying to balance and do whatever they do. I also pretty sure they're looking for higher levels. We don't want high levels of lactic acid.
No, they don't want it either. They want to be able to manage with it, but get rid of it quickly.
Uh-huh. Okay. But when you have a sick person who's 80 years old, who's got infection that's spread throughout the body, and now they're in septic shock, okay, and they have a high lactic acid reading, they,
Likely not.
you know,
likely.
no, you can't know. You're not gonna know. Okay, I test it in the back of the ambulance. I'll test for it. Okay, I had a patient with lactic acid of 12, and he died.
What's average, not what's normal?
One.
Oh.
Yeah. Okay. So we generally say over 4 is bad. Like, you know, between 1 and 4, 1 and 2 is sort of normal. 2 to 4 is okay. You're early, but 10, 12, this is bad. Okay, these patients don't survive the night sometimes. So, all right, 4 to 6 minutes. Right. Remember this. 4 to 6 minutes without oxygen, cells begin to die. Okay, you should know this from CPR, right?
Theoretically, septic shock comes from respiratory
All
problems.
organ damage kicks in.
Could come from any problem, but it would be exacerbated by respiratory problems, yes. Doesn't really come from it.
Well,
Starts
the way
off
you were
with,
explaining it now,
starts with an infection.
but a respiratory
Then it goes,
infection.
no, it could be anywhere. Could be anywhere. And it just spreads to this. All right, respirations. What do you need to know about them? Well, the normal rate of respirations for an adult is between 12 and 20. That's wrong. Shouldn't be BPM. Should be RPM. Rests per minute.
Breath per minute is BPM.
No, that BPM is beats per minute.
Oh.
Should
Could be breaths per minute.
Yeah, should be rest per minute. I think.
Should be Q for rest.
That's right. Rhythm. Right? We need to look at the rhythm. How are they breathing? I will teach you soon a couple, maybe one name for a weird breathing rhythm.
Stokes.
Oh, yeah, okay. Oh, you have some here. The one I want you to know will be Kuzmal's breathing, but not tonight, okay? So there are names that we give to various irregular breathing patterns and styles. By all means, if you want to look these up, find out, read about them. I don't even know if they'll be in your textbooks, but it's very interesting stuff. Just like the heart has rhythms and we have names for the various rhythms of the heart, These are some of the names for some of the rhythms of breathing. There are not as many breathing rhythms as there are cardiac rhythms. But Kussmaul's I will talk to you about later on. So regular, irregular. When you look at a person breathe, is it 12 every minute? Okay, each time is 1, 2, and in and out, and in and out. Right? It's not panting and then no breathing and then something else weird. Right? It's just regular.
Is Kussmaul's like a dialysis patient?
No,
Like with a kidney failure?
no. Usually see it in diabetics. We'll talk about it on another night. Quality of the breathing. These are words you should know. Labored or non-labored. Labored means they're working hard, right? Everybody in the room, I look at you, nobody's really working too hard. I mean at breathing, all right? No, I meant both, okay? So it's something that you're just doing, right? You're not like, you ever seen somebody working to breathe?
After you ran
Yeah.
Okay, all right? Deep and shallow, right? Very deep. Shallow means panting like a dog would breathe. Right? Adults shouldn't be breathing like that. Chest expansion, right? That's normal for the chest to move out, move in. And again, work of breathing would fit with the labored or non-labored, okay? Work of breathing. How hard do they have to work? And when people have real difficulty breathing, so we get called for difficulty breathing. Again, I don't know statistics on stuff, but of all the calls we get, this is a big, very, very common thing. Okay, the call for the difficulty breathing, for the disc breather.
Does oxygen help them breathe much easier?
Depends what the problem is. We'll talk about helping them a little bit later on.
Is that because there's a symptom that they're talking about? Meaning, when there's blood flying out of someone's hand, that they can see the sign and understand it, but
Right.
the symptom of difficulty breathing could mean different things to different people.
Yes, yes. But it can also mean they're having difficulty breathing. We'll get to some of the pathophysiology soon. Let's just stick with the defining the terms, all right? Lung sounds, all right? Now, what's the deal with lung sounds? Man, I've been teaching this, as you know, for a couple days. And many, many years ago, I used to tell EMTs, you need to be able to differentiate between 3 different lung sounds, lung types. It was very easy back then. What were the 3? There was good lung sounds, right? Good lung sounds meant that you just had to find consenting adults and put a stethoscope on their back and listen to what good lung sounds sound like. There were bad lung sounds, and that was anything that didn't sound like good lung sounds, okay? And then there were no lung sounds, of course, that being the worst. And yeah, that was apneic. If you don't know that word, you should know it from tonight on. Apneic. Okay? Apneic means a. Remember, the prefix a in Latin before anything means without. Not there. Apneic. PN, we know, usually means something to do with breathing and lungs, right? As in pneumonia, right? So if somebody asks you to spell out a word and there's a letter P there, you're like P as in pneumonia. Okay, I do it all the time and they're like N? No, P as in pneumonia. And they just can't. They just can't. It's just way too much. It's hilarious.
Pneumonia.
You gotta try it. You just gotta try. No, P as in pneumonia. N? No, P. So you gotta try a couple of times. It's a lot of fun. But anyway.
That is in Yiddish.
So. Schwer zu min. So that was back in the day, okay? But a lot's changed. One thing has changed is that we've given EMTs a drug to use. All right, yeah. So you have a larger scope of practice than, let's say, I had when I was an EMT. Okay, because I didn't have this drug. This drug that we've given EMTs to use now is known as albuterol. We'll talk about it later on we do pharmacology lecture, we'll talk all about the drugs. The bottom line is, to be able to use albuterol, you've got to be able to listen to and identify wheezing. Because that's what it's used for. It's used for the patient who is wheezing. So if you only know good, bad, and none, well, one of the bad ones is wheezing, but not all the bad ones are wheezing. Okay.
That sounded like Strider. That's,
Yeah.
That's more of the,
Really did.
that was coming from up here, not from
It really did. Very good. So, your wife told you that?
Yeah, yeah.
I have a kid with lung issues, so.
So the question is, what do all these mean? So we have wheezing, we have diminished. Well, diminished it means like none, right? Stridor, we gotta learn what that is. Absent also means none. Rails, okay?
It's now crackled.
Right, rails, crackles, different people say different things, that's fine. Dr. Rosen says crepes. That's what they called it, I guess, in South Africa 100 years ago, when he became a doctor. So, that's all good. But I know what he's talking about because I've been working with him for so many years. But, so this is the situation. So, yes, you've got to start listening to lung sounds. The best lung sounds to listen to are normal lung sounds, because then you can learn that one. That's the hardest one to master. Normal. Once it doesn't sound right, then we can start to figure out, you know, and there's things online. Some of them are really awful. Some of them are okay. You can find different lung sounds. The two that I really think you should be familiar with are stridor, and that's most common in children, and we'll talk about that, and wheezing. Okay, wheezing really is the one you want to know in order to be able to use the medication.
What is Strider?
Well, we'll get to it. Stridor is an upper airway barking type noise, but it's coming from the upper airway. So the lungs themselves should sound clear. All right? Wheezing is a lower airway problem. So if you want to write something down, I would write that down. Stridor,
Striders is normal.
upper airway. Wheezing, lower airway.
Striders is normal for pneumonia.
No,
Bronchitis.
no, no, no.
No, bronchitis is lower
No.
airway.
Is that where sleep apnea comes from? Apnea?
Well, what?
Yeah, no. Sleep apnea.
Sleep apnea. Well, the word apnea means not breathing. And that happens usually. It's the tongue that is the biggest offender and the worst problem for all these sorts of things where the tongue blocks the airway.
What causes the leg to twitch during sleep apnea? Is that related? Serious question. I've watched people with sleep apnea and their leg twitches while they're sleeping.
It may be a carbon dioxide buildup problem. I'm not 100% sure. All right. This stuff you gotta know. All right. We're starting now with the first diseases, first problem. First one we're gonna talk about is called COPD. Okay. You gotta remember this. You gotta know what it stands for. COPD, chronic obstructive pulmonary disease, COPD. You all got this? You all with me on the same page? All right, there are two big diseases that fall under the heading of COPD. All right, one is called chronic bronchitis. We'll talk about it. The other one is called emphysema. Okay. Let's talk about the word chronic for a minute. In medicine, in emergency medicine, we're going to use words chronic and acute. What's the difference?
Like?
Chronic means it's
acute
all
is
there.
sudden and chronic is last.
Good. Acute is something that happens suddenly, and chronic is something that the patient has and will continue to have pretty much forever. All right? Unless there's some cure for it and it completely goes away. So chronic and acute. Let's talk about chronic bronchitis. This is not the bronchitis that a small child may get, a respiratory disease that may be viral or maybe bacterial. This is not that. This is something that somebody has gotten, usually older in life, very often has to do with smoking or factory work or other pollutants that have affected the lung, okay? This is not something that a little child wakes up with a fever and difficulty noise in their breathing, and they go to the doctor and they've got a bronchiolitis or something. This is different. This is chronic bronchitis. So the slang name is the blue bloater. Blue bloater, you see the B's for bronchitis, okay? Why? What?
You have to know this thing.
It's good so you remember the problem.
Sounds very
Right? They turn blue. What's blue? What does it mean when a person turns into a Smurf? What does that mean?
Oxygen.
Right?
Hypoxia.
Right, so hypoxia equals cyanosis. Okay, the medical term for being a Smurf. We don't say that, right? We say that they are cyanotic. This comes from the word cyan, which graphic designer guy will tell you is a common word in color computer stuff, right? Cyan. That's a common word for blue.
Main color.
It's a main color, okay? So cyanosis, or the patient becomes cyanotic. You have to be able to parse these words in English, right? And know which one means what, okay? So the patient could be cyanotic, or they could have cyanosis. Now when we talk about cyanosis, we're usually talking about central cyanosis, which means around the lips and the face. Okay, there is peripheral cyanosis where the fingers may be a little blue. But I'm talking about Papa Smurf, okay? When you walk in and you see somebody is blue, all right? You really see it, like this chair, okay?
They're conscious and breathing and they're blue?
What?
They're conscious and blue?
Yeah, yeah. All right? That's hypoxia. Remember this. This is all connected. This is stuff you've got to know.
How do you spell the cyanosis with a C?
CY.
CY?
CYN.
C-Y-A-N-O-S.
Yeah, there's no P in it.
Cyanosis.
Yeah, believe it or not.
P like in cyanosis.
Very good. So what is it? Well, it's inflammation of the bronchioles. Cilia. This is a friend of mine. No, just joking. Cilia are small, tiny, microscopic hairs that are found on the inside of most of your pipes and tubes inside your body, okay? They're called cilia. And they can knock, their job is to knock out all the garbage, the schmutz, right? To knock it out and to allow just pure filtered air to enter. Sometimes they can't do that properly. What?
We all got the smoking speech.
From me?
No. When they give it to you, they tell you it kills the little hairs.
Yeah.
That's why I can't go to the lungs.
Right.
I never knew about that.
You're gonna hear. You're gonna get it from me
In
also.
Yeshiva, you guys never got the smoking
Not
speech?
the hair
Why
part.
smoking is so bad?
Okay, it really is. You'll see why. All right. I call the cigarettes the emphysema sticks. Okay, because that's what you're doing.
Cancer stuff.
You can call it that. It doesn't scare people enough because that became like big deal.
Well, the commercials should.
So,
I used to
Yeah,
smoke,
right.
but now I'm dead.
Yeah.
so,
She died, by the way, that woman. She did that.
Seriously?
Yes. A couple years ago.
By the way,
Alright.
it didn't stop any smoking,
No.
by the way.
no, I don't do the
got so
surgeon's
stressed.
warnings.
That's
Nothing.
not one.
Nothing.
I love those surgeon warnings.
Surgeon
I
warning.
love those.
Yeah. Okay.
So blunt.
Yeah.
What's flagella?
Flagella.
Flagella.
I think are they smaller cilia or
What's a figula?
It's a fake no.
Turn the camera for a second.
All right. Well, let's just stick with. Let me finish.
Little hairs.
Yeah.
Yeah.
No, I just remember from 8th grade bio.
Let's just
In fairness, she's in 10th grade now, so.
let's just get through this because I need you to stay on focus. I need you to focus. Chronic bronchitis. Okay, we have this problem now. Chronic bronchitis can lead after a certain amount of time. Don't ask me how long it takes. Can lead to emphysema. So emphysema is worse. Okay. Emphysema are known as pink puffers. So they're no longer turning blue. They're staying pink. Again, the pink puffer for the P of emphysema. Okay? Now, it can be caused by chronic bronchitis that got worse, but here's the main thing. Here's the main thing. Listen, emphysema has a problem called atelectasis. Atelectasis is the collapse of alveoli. The alveoli start to fall apart, lose elasticity, not able to do its job, and so all of a sudden we have less lung surface area for transfer gases. Okay? So they have big problems breathing.
So with every breath they're getting less oxygen
Yes.
into their cells.
Into their actual, yeah.
So their whole body's getting messed up.
Yes.
What happens?
Yeah.
You
The body absorbs less
Okay,
oxygen.
the alveoli fall
They have
apart,
fewer alveoli.
and then the word for it is atelectasis. They may ask you,
Yeah.
That's
they may ask you what is the similarities or differences between the two. Okay, the big difference between them
Blue and
is
pink.
this atelectasis, the problem with the
And
alveoli.
bronchitis is
Doesn't-
an inefficiency
Yeah.
in the alveoli.
Yeah.
This
Here,
is a
it's
breakdown.
actual, yeah,
Destruction.
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 when you say the
Okay.
differences between the two, you're talking about bronchitis and emphysema.
Between chronic bronchitis. Don't say bronchitis, because that will confuse you and you may get all scared if you hear a little 6-year-old kid got bronchitis. That's,
Even though they
you know.
technically have bronchiolitis, not bronchitis.
yes, yeah, they do. Alright? So bronchitis and emphysema. Now, just to go back to the opening, these are the patients that end up with the hypoxic drive. Okay? Told you I'd tell you who gets it. These are these two groups of patients.
So when the electasis die,
Yeah. No, when the alveoli die, fall apart. Electasis is the
is the condition of the destruction
Yeah.
of the alveoli.
Yes.
Then the body cannot function on
Right.
its own. It needs that
Needs-
drive.
Okay? So these people have this hypoxic drive situation. Alright, here's some signs and symptoms, quite a lot, for COPD. We're going to go back to just saying COPD, but you know that it means both.
Yeah.
Yes? Good.
COPD includes both.
Chronic and
Emphysema and chronic
Chronic
bronchitis.
Good. So SOB. SOB is a normal medical abbreviation, accepted medical abbreviation.
So shouldn't I not get that EMT that said that to me?
Right, you shouldn't have done that. Alright, so the patient will complain of being SOB, only here means shortness of breath. Use of secondary muscle. It can be both. They can complain of
the
it,
complaint is a symptom.
you can see it. Right, right? So use of secondary muscles. I'm not going to go into all the different muscle groups, but if you can see those, can you see the muscles over there sort of pulled tight, right, popping out? So that is a muscle group there. Here you have intercostal muscles that are being used. When you just look at somebody breathing, you're not seeing like, this whole massive production here to breathe. This guy is having a hard time. You can just see it, right, when you walk in. Cyanosis, right? We know what that means?
Blue.
Cyanosis?
Blue.
Good, blue. Barrel chest, okay. So barrel chest is very interesting. Maybe you can confirm or deny. If I was to do weights on a regular basis, right, I would grow strength in the muscles that I am using to lift the weights, and those muscles would get bigger, right? He's confirming. That is true. It's only a hypothetical, okay? Don't get worried, all right? No, I once figured out that I had an allergic reaction to exercise. I got red and sweaty, and obviously it was an allergic reaction. I wasn't supposed to be doing it. I stopped. It's okay. But I did try. All right. So, barrel chest means that since they are working so hard, they're working so hard with their chest wall that they're actually building these huge chest muscles. What do you call them? Pecs, right? They're building these huge chest muscles just from the work of breathing. Well, at the same time, it's killing them because they're not building them in a healthy, good way. They're building them by, this is the only way they can get air in and out.
Time.
No, it's over years, yes.
Wow.
So they get like these ripped guys, but they're really about to die.
Yeah.
Well, I
Okay.
call those skinny fat people.
Okay. Small sentences. This is very important. You'll see this a lot. You'll see this a lot, guys, in the street, in the field. This is really important. We call it 1 or 2 word dyspnea. Dyspnea. Now, apnea means inability. Dyspnea means difficulty in breathing. 1 and 2 word dyspnea means when you see a person and the most they can speak is 1 or 2 words without having to take a breath, that is a clear sign that there is a respiratory issue going on here. That's all you need. Again, what you do as EMTs is all about looking, listening, smelling, thinking. It's all about what you see. It's no good coming in and being on your phone and worrying about whatever's going on the phone, and you can't. You gotta come in, you gotta focus. Focus on that patient. What is wrong? What do I see? Okay, what are they saying? Is it nothing? All right, is it absolutely nothing? Or is it something pretty serious? And people miss these things. They miss them because they don't come in focused enough. Okay? I don't want to go into too many war stories, but people ask me, when either they'll say, oh, did you see me? You were working on a patient in the middle of the street, and I was there, and I was waving at you, why didn't you wave back, or something? And I'm so focused on what I have to do, I don't see or hear anything else. All I'm focused on is what I have to do to either save this patient, resuscitate this patient, move this patient, whatever it may be.
Without tunnel vision.
With no tunnel vision when it comes to the patient, but I'm not seeing all this other nonsense that's going on around me. I don't see it. Okay? So, especially in high stress, big crowd situations, people get very upset. Why didn't you acknowledge me? I saw you. Really? Really? So,
It seems to be kiddish, going for the challenge and
that's it. There's nothing else.
Science doesn't go for the focus.
Focus. Yeah, but for you it would be more for the fruit bowl, no? Okay.
You don't have to fight with anybody but the fruit.
The women.
Always put it in the women's section.
The women say that's where it belongs.
That's where I end up.
There you go. Small sentences. Look for this. If the patient tells you, I can't,
Tripod position.
right? If they're doing that, Houston, we got a problem, right? Bells should be going off in your head. That's it. That's all the clinical information you need. You can make a diagnosis on that, right? So, no, it's not, sir, okay, would you like to walk down 4 flights of stairs now? No, it's oxygen, vital sign, stair chair, elevator, right? And drag his ass to the ambulance, okay? Right? And if he's not stable, or you need medics, you need help, you need backup, so get him. That's fine, okay? Deep, very deep or very shallow respirations, obviously, if it's not just normal breathing that you would expect, inability to catch their breath, either you see it or they tell you. Body positioning, this is what I told you. Had a guy recently, was literally standing outside by a wall like this, and he was trying to breathe. This is how he's standing, okay? Oh, I went past Shiva. All right, so if you see that, and the EMTs are all standing around watching him, talking to him, and I'm like, guys, do you see the way he's positioning himself? He can't breathe. Where's your stair chair? Okay? Let's go, let's do something. Get oxygen on this guy. Alright, so these are some of the signs and symptoms that you may see. I just want to repeat again, reiterate.
That's also a sign of intoxication.
Just let me reiterate that signs and symptoms can be shared with many different problems, diseases, whatever it is. They can be shared, okay? You're going to see when we learn about MIs that you're going to tell me, oh, well, all those are the signs and symptoms of shock. Or, you know, everybody having in shock maybe is also having an MI. No, it doesn't work like that. So the signs and symptoms are going to overlap, okay? And you can never make 100%. That's why EMTs are not supposed to diagnose the problem. You're supposed to find all the information, document the information, and fix what you can.
But it's always there's that one specific
Right.
thing that
Okay.
differentiates it from the
Okay.
others.
Not
But for the
always,
most
but
part,
sometimes.
Can we go
The other thing is, out of all these, your COPD may right now have none of them. How about that? May have one, or may have all of them. Right? So you just don't know. You don't know. Like I always say to new EMTs, the patients don't read the textbook. Okay? If every patient having an MI, a heart attack, would read the textbook, chapter whatever, how to have a heart attack, what they're supposed to say, what they're supposed to feel, what they're supposed to look like, our jobs would be so easy. Okay? But they don't. So that's what I always say. The patient doesn't read the textbook. Alright? So, it's not easy. It's not easy.
They say you should cough, right? Didn't they say you're supposed to cough if you're having a heart attack?
No,
It's like
no, don't give me these.
CPR.
No, don't give me this Bubbermeister.
If your heart.
Seriously, I can't believe you said that because you, I thought were somewhat intelligent. You really let me down. Do we do CPR on somebody who's alive?
I said self-CPR.
Again, do we do CPR on somebody who's alive?
Would coughing
And
I
it's a
wouldn't.
rhetorical question.
On myself, maybe.
would coughing be as good as dipping your heart in milk?
Yeah. You can have another day. Okay.
I'll send you the medical journal.
Yeah, please. Yeah. Yeah, New England Medical Journal, right? Yeah. Yeah. And he's sending the one where you dip your heart in milk and, yeah, we'll make cocoa. Okay. All right. Treatment. This is what you all wanted to know, right? What should we do?
Nothing.
No. Oxygen. First of all, POC. POC, learn that acronym. POC, we're going to use it a lot. Position of? Comfort. Minimize exercise and movement, okay? So it's not, okay, ma'am, please follow me down the 4 flights of stairs. No. Keep patient calm and assured. It's no good you're going, oh no, you can't breathe, no! No, I don't know what to do, I can't do nothing, no!
No big deal.
It's not helping, okay? I tell you, it's really important. When you're in front of a patient, it doesn't matter if you're the top surgeon general in the world or if you are the first EMT out of class, it doesn't matter. You have to have a professional demeanor. You have to be in full control. And if you're not, then you have to pretend that you are. Okay? Until somebody of higher rank or seniority or whatever it is takes over. You have to have that professional demeanor. You have to be in control of the patient and of the scene. It's very easy for me to get up here and say this. Okay? I'm doing this a couple days. It's very difficult, very difficult. It takes time, takes practice, okay? But you gotta make the patient feel that they are comfortable and they're in good hands. Because they're relying on you now. You're their doctor right now. You're the best they got, okay? Listen to lung sounds, okay, we spoke about that. Oxygen administration, we'll speak more about that. Reassess vitals. Prescribed inhaler, we'll talk about that on another night. You can always go for ALS and transport to the ER.
You give oxygen before you listen to lung sounds? Or if the guy's showing signs and symptoms of.
Do you give oxygen before you listen to lung sounds? Absolutely. You can give oxygen just based on your clinical
Based on the
way.
signs and symptoms.
Okay, it's out of order then. Is this in order or not?
No.
You can listen to lungs while giving oxygen?
Can we have 10 minutes to read the article and cough?
No, not right now.
It won't take 10 minutes.
Well, you can listen to the lungs while giving oxygen?
Yes, yes,
It
absolutely.
doesn't affect the
Does
way-
not affect.
Medical evidence.
Alright, you'll practice giving oxygen and all that
You hear
stuff.
wheezing if the guy's getting oxygen.
You will, nothing to do.
He's still gonna have that, he's still gonna have those problems, in other words.
Are we skipping that other one?
When you're giving him oxygen, it's not like you're giving him medicine.
Just for now.
His lungs open up, you're just giving him more oxygen to take into his
Alright, that was COPD, which you need to know. COPD, you need to know what it stands for, you need to know the two diseases that fall under its, its encompassment, which are chronic bronchitis and emphysema. You need to know some of the similarities, which are all the signs and symptoms, are all the similarities, and the differences, the big one is atelectasis. Also, the COPD may look blue, and the emphysema may be pinker. Okay? Alright, let's talk about asthma.
What was the fancy word you used for chronic bronchitis? Did you use a fancy word just now?
Blue bloater.
Blue bloater.
Ah.
That was like the slang, not fancy. Blue bloater. Okay? Alright, let's talk about asthma. Anybody know somebody with asthma? Okay, usually there are many people who know. Okay, let's talk about it, let's understand it, let's appreciate it. First of all, what I want each and every one of you to know is that asthma kills people. Asthma is not a joke. Asthma is real serious stuff. Okay? It's one of those things that can just turn and be really, really deadly. So never treat it lightly. Never think it's a joke. Asthma is always serious. Well, what's going on? So here we have a normal, maybe it's a bronchiole, doesn't matter. And what you see is this hole here, which we call in medicine a lumen. Lumen is the name for the inside of any pipe, all right? It's called a lumen, all right? And this is normal airway. What's normal about it? Well, it's nice, it's wide open, it's being held open, it's air can get in, air can come out. It's all good. It's all good. This is what a normal airway looks like. This is not good, okay? This is known as bronchospasm, okay? And that is the essence and the key to understanding asthma, right? Bronchospasm. The airways themselves, whether it's a bronchiole, usually it'd be a bronchiole, gets twisted on itself and spasmic, okay? There's also, it gets inflamed, all right? Look at that, look at the wall thickness here compared to the wall thickness here. And that's partially because of the spasming, all right? It also gets filled with mucus.
Where's the mucus coming from?
Don't worry about it. Right now, okay? Don't worry about it right now. Right now, understand these concepts, okay? So, normal airway, asthmatic. Well, I don't like to use the word asthmatic and asthma. I like to say bronchospasm, because that's what it really is. Okay? Asthma is a medical term. That's fine, but it's really bronchospasm. All right? Here it's showing you that all this is this little bronchial tree part over here. All right? All right. So back to this
That
slide.
little tree is the beginning and the ending of asthma. Where it comes from. That's where the asthma comes from. That little.
Well, that going on all over the lung. Okay? Now, this looks like, I don't know, eyes and then a starfish or something. That's why I don't like this picture. Okay, I don't particularly like this picture. It really doesn't show as clearly as this picture, all right? I have it here, whatever, it's one of those things.
They don't make them like they used to.
This is a new picture, and that's
That one's
my
20
old.
years old.
Yes.
Near my hands.
So I don't know. This looks like two moons and planets and some stars. I'm not
It's
sure.
It's supposed to be showing blood flow going.
Well, hopefully not blood flow.
Yeah.
Hopefully
air.
air.
Oh,
So
that's
one of these would be oxygen, the other would be CO2. It's all sort of good. All right. Basically, it's a good one. This is one with bronchospasm. All right. Let me go through some of the things. Let me talk about it. All right. So inflammation or swelling of the bronchioles. We spoke about that. Now, where are the bronchioles? I don't want to go all the way back to slide 1.
In the lungs.
But where are they? They're in the lungs, and therefore they're in which airway? Upper or lower? Lower airway. So understand, asthma, lower airway, wheezing. Write these 3 words down. Write them 100 times. Remember, these 3 things go together. Asthma, lower airway, wheezing. Even if you don't understand right now, it's really important that you keep these 3 concepts together in your head.
So people with asthma wheeze.
Yes.
The acronym is
We'll talk, what?
ALO. In the medical field, we call it ALO. No, just made it up.
It's okay, by the way, to make up acronyms. It's a great thing. You'll see later. You're gonna get a whole
lot of them.
lot of them that I made up that you're gonna be using. Okay, all the time.
Is it in the Davis Dictionary? I should publish one.
Should publish one. The medical dictionary.
Yeah.
And yeah, he's
It's like the safer
There's
Russian
a lot of
tables.
bad words in there.
yeah, there would be. There really would be. And I'm really trying to be on best behavior. The covered, Chile. So,
Chileans.
right, so don't try to get me to misbehave. Okay. Also, I was told the Choshev yeshiva that we're in, we have to, heilige walls. They don't want to hear, such talk.
You go as far as tefillah.
I can go till tefillah. Yeah, this is assuming that I would do tshuva. This one I can handle, so maybe we should put this one first. We should rearrange the order.
I don't think they'll notice.
They're still traumatized with the wood towers.
What did I leave over there?
But not you, the kids.
I said they wouldn't notice if you moved it.
I'm traumatized.
Alive anywhere close to that.
I'm traumatized.
You didn't see the picture of the Twin Towers?
I didn't see.
Yeah.
I can give you a
Who erased all my stuff from the? You did.
PMS?
Yeah, you were scared then.
erase PMS.
6 fingers, we're gonna scare some people.
The 6 fingers. They were.
PMS really got me. It's been great, you know what I'm saying?
Wow, that's funny. Can you imagine the teacher comes in and she's like, "Hello?"
We put a little pink heart around it also.
Wow.
And that's without the rule of 9s and the 1.
Right.
They look forward to Monday
What was the last
morning.
day?
They really do.
What was the last thing? It's a lower extremity, symptom is wheezing, and
Asthma.
What's the matter with him? See, he was a class. Good. So back to business. What's asthma? Inflammation, swelling, right? We saw that on this picture. I don't want to keep flicking back to it, but you get it, right? You get the picture? There you go. So it's defined by bronchospasms. One of the things now one of the toys that ALS have now is the ability to measure somebody's CO2 without intubating them. All right, so we have this prong thing, goes in the nose. It looks like a nasal cannula, and it attaches to the monitor, and it actually can see the inhale, exhale, and the CO2 that's going on. It's fantastic. And I can actually see on a graph if they have bronchospasm. So it's amazing. Even if you're in a noisy environment, and you just can't hear it properly, or whatever it is, you can see it, black and white. Comes out on a strip. It looks like a pleth, we call it. Okay, and I can determine.
It's like a breathalyzer for asthma.
Yeah, it's really, really good. Wheezing,
What's the
okay.
level of
Doesn't it get
CO2 that
so
you use?
simple, why would they just?
What?
What was the level of CO2?
That's true.
Normal CO2?
Yeah.
Normal CO2 in a human, yes, I'll tell you, it's not something you need to know. Normal CO2 is between 35 and 45. So the optimum number is 40. That's the optimum number of CO2, end-tidal CO2.
CO2 exhalation.
Yeah, end-tidal. 35 and 45. That's your CO2 number that you want to maintain. You will not be tested on that until you get to medic school. Okay? Alright. So wheezing, here. When do you typically hear the wheezing? You usually, quotes, usually hear the wheezing during exhalation. And we call it an expiratory wheeze. Again, in asthma, it's known as an expiratory wheeze. That is the wheezing that you hear typically with your asthmatics. Meaning they breathe in, quiet, regular. And when they breathe out, you'll hear the wheeze. Okay? Remember, a one breath equals one inhalation and one exhalation. That's not two. That's one breath. Okay? So wheezing, remember that usually we're looking for what type of wheezing?
Expiratory.
Expiratory wheezing. Pursed lips. Pursed lips are where they push their lips very close together. Breathe out through. It's trying to create a change in interthoracic pressure. You don't need to worry about why they do it, just that is one of the signs that you may see, that they close their mouth and just leave a crack open to try to get the air out through there. Agitation. Agitation means that they're on the way to being AMS. They're not acting right. And why would that be? Why are they agitated?
They're not getting enough.
Mucus in
Not getting enough
They're not getting enough oxygen to wherever they need to go. Anxiety, same thing. Tripod position, I'm sure we've spoken about this before, right? Where they sit with their head between their legs.
Oh, like this with the hand now.
No.
Head between their legs, typically. Okay, that's the tripod position. Okay? And accessory muscle use, we've discussed using those extra chest muscles. Nasal flaring, sometimes in children, cyanosis, tachypnea and tachycardia. Let's make sure we know these words. Tachypnea, tachypnea. What does it mean?
Fast breathing.
Fast breathing.
Like I said.
Brady.
Tachycardia,
Slow.
Fast heart rate.
fast heart rate. Do we know the opposite of tachycardia?
Bradycardia.
Bradycardia, just Brady. All right, incomplete sentences. I spoke about this before, right? It's called one or two word dyspnea. And silent chest with 3 stars after it. Let's talk about silent chest.
3 stars.
I almost did feel it. I have to be careful.
Nah, beer in this right now.
Silent chest is the worst type of asthma. The worst type of asthma. Okay? So you come in and maybe the family tells you, you know, Bob over here has asthma and he woke up and he's just can't breathe, he can't talk, and you see all these problems going on. So you're a good EMT, take out your stethoscope. Meanwhile, someone's preparing oxygen and albuterol, right? And you listen to the chest. And what are you expecting to hear?
Wheezing.
Expiratory wheeze. Meanwhile, you put the thing and you hear nothing. You move it because you figure, okay, I'm in the wrong place.
No.
So you move it and you hear nothing. All right, let's try the other lung. Nothing. Silent chest. This is your none breath sounds. Remember good, bad, and none? This is none.
But he's still.
Remember this. This is the worst type, the most serious form of asthma.
You see the chest, right?
You might, you may not. They're alive.
They're
They're alive.
Yeah, they're breathing. Yeah.
They're
How's he
alive.
breathing?
They are breathing, but no air is getting in.
Is
Or
that
it's just
obstruction?
getting in.
Slightly.
Is that obstruction or they're tired?
This is asthma usually.
Feels like you're drowning.
No, but they're so, are they
No,
fatigued?
does not feel
It's a
like that.
bad obstruction.
Are they
Yeah.
fatigued?
I have
That's
asthma.
why
Is it extreme?
it's silent?
No, it's because the bronchospasm is so severe and it's diffused, it's everywhere in the whole lung
Minimal.
that there's almost no
Here, getting through.
air getting through any of the pipes to the alveoli in order to.
It's only a matter of time. I mean,
Yeah, it's a matter of time and they're gonna go.
So I guess someone could have silent chest without asthma if it just
Where's tired asthma?
to breathe eventually.
Do you host this? Or?
Who cares if
Not really though, because you're automatically gonna be.
You're gonna breathe. Yeah.
It's an involuntary.
No, it's involuntary, but the body just has no.
Usually it's asthma or COPD that you get this silent chest, okay? Usually. Remember this, this is the most severe form of asthma. This needs rapid intervention on your behalf. Get medics, but there's plenty you can do, and we'll talk about that. Okay? So here's the better picture. All right. I'll show you this when we do, hopefully, pharmacology. I'll show you one of these. Many of you will have seen it or whatever, but I will talk about this. Good questions to ask asthmatics. So, have you ever been intubated? Well, the problem with that question is that half of them won't even know what you're talking about. Okay? So there's a much better question to ask. Were you ever admitted to the ICU? Okay? In America, in New York, you don't get an ICU bed without being intubated. That's it. It's that simple. Okay? So, were you ever admitted to the ICU because of your asthma? Now, you're asking this for a number of reasons. You're asking this for a number of reasons. You're asking it, first of all, to find out how bad this is going to get. Meaning, if they've got so bad that they ended up in the ICU, intubated, on a respirator, that means that you're in for a rough ride. You better be prepared for anything to happen. Okay? So it's a great question to ask an asthmatic. Ask if they're getting very tired, right? If the breathing is tiring them out, this is a bad sign. All right? We'll talk about what you're going to do with your medications, all right? Again, silent chest, wheezing, and accessory muscle usage. All these things are things you'll be able to figure out, see, and deal with, all right? We'll talk more about the medication and your treatment on another night. Just tonight, learn about the actual disease itself. This is called APE. We call this APE, stands for acute pulmonary edema. Okay, acute means happens rapidly, suddenly. Pulmonary means lungs, and edema, fluid where it shouldn't be. Okay, so left-sided APE, and we're going to talk about over here right-sided. What I want you to do is to just think of congestive heart failure as a chronic problem. See here? Congestive heart failure. This is a chronic problem that they may have all the time. You ask elderly people what pills do they take. Very often they'll tell you they take a water pill. They call it a water pill. In New York, the old babushkas, all right? That's what they call it. I take a water pill. All right? Now, let me explain to you what that really is. What that water pill is, it's what we call in medicine a diuretic. A diuretic. Someone Google it. I don't know how to spell it. All right.
Diarrhea, but.
No, not as many R's. No. All right? It's a diuretic. What that does is it removes excess water and fluids from their system into the kidneys and makes them piss it out. That's what it does. Okay? And it's called a diuretic. And they could take 20 milligrams, 40 milligrams, 80 milligrams, whatever it is, once a day, twice a day, depending on how much fluid is in their body. They may have fluid in their ankles. They may have fluid in their lungs. They've been prescribed it by a cardiologist or by their doctor. And this is very normal as people get older. But understand, if they're taking a diuretic, understand, the most common one, most famous one, is called, anybody? No.
Coca-Cola.
The most common one, the most common diuretic that people are prescribed, the first one is called Lasix. Lasix, also known, same drug, furosemide. Okay, it's a generic and a trade name. So this is the most common diuretic in New York that people are on. There are others, I know, I'm not going to go into them all, because there isn't time for all that. But, whether it's right-sided heart failure or left-sided heart failure, what's happening is that there is a problem with the pump managing to force blood and fluids forward. Okay? Now, let's think about the left side of the heart for a minute. Where does the blood come from to the left side of the heart?
The lungs.
Where does it come from? It comes from the lungs. Very good. Through the pulmonary vein. Very good. Because it's going to the heart. So, what happens if the left side of the heart at this point starts backing up? Starts backing up.
Don't you have the valve for that?
Oh, very good. But now the valve gives up. It's not perfect. And it can only, it's like, you know, the drain, the sewer system. Do you ever see it back up? You live in Brooklyn, right? We see it back up, right? Why is it back up? Too much, right? So the same thing with the left side of the heart gets too filled with blood coming from the pulmonary system, from the lungs. It will back up, and where's it going to back up into?
Back into the lungs.
Into the lungs, and now we're going to have a problem. Now we're going to have a problem.
But why is it backing? Why is there too much in the lungs? Because it's not.
Because it can't pump forward. Can't pump forward. So now it's got to go somewhere. It's blood and fluid and stuff in there. So the blood's got to go somewhere. So now it backs up into the lung. And it's going to fill the lung with fluid. Okay?
Well, it's going to fill with blood too? I mean, what?
Yeah, blood, yeah. Yeah. So this is what is going on over here. And what happens is the alveoli will start to soak it in. Okay, soak in all this.
Soak in deoxygenated.
Yeah, whatever. No, it's actually oxygenated blood. But it's going to go into the alveoli. It's left the blood. It leaves the blood supply and goes into the actual lung. Okay? And so you drown in your own lungs. And that's exactly what this is. They drown in their own lungs. Okay? And this is what's going on with acute pulmonary edema or CHF. When they have an exacerbation, they have an attack of CHF. And I probably showed you with the bottle, right? If you lay it down, or if you, right, these patients need to be sat straight up. Straight up. Okay, Fowlers, not even semi-Fowlers, which you may say in the book. You're going to use, there's a brand new device that just was approved this week, I think, for EMTs in New York City, which is called CPAP. Medics have been using it now for a number of years. Saved numerous lives using it and prevented them from going to the ICU and being intubated.
And now
okay? Now EMTs are going to be allowed to use it. I'll show it to you. I'll explain it to you.
What does it do?
Forces air into the lungs, which forces the fluid out of the lungs.
Where through what?
Positive.
Pushes it through back into the system?
No. It goes out into what's called the third space. Don't worry where it goes right now.
There's an extra space. The whole of the body of an
Positive airway.
Is it?
Is that what they use with sleep apps?
Yeah, it's similar. Similar, that's BiPAP.
Wouldn't CPR cause a pulmonary edema?
No.
Well, if you're doing compressions, wouldn't
You're
it?
sending it the right way.
But I mean,
It
wouldn't-
flows the
wouldn't
right
flow
way.
the wrong way.
Naturally, it will flow the right way.
Unless someone has congestive heart failure.
Yeah, well then all bets are off, right? Okay.
Then maybe you shouldn't be doing CPR then.
So, alright, so this is what I want you to know. I want you to know a few things about about APE and congestive heart failure. I want you to understand that the sound that you will hear is called rales. R-A
Where is this? What are you talking about?
LES.
L-E-S, rales. This is the lung sound that you will hear of a patient who is in APE.
Bubbling, right?
Yeah, it sounds like water swishing around inside the lungs. Every time they breathe, you'll hear swishing around of water. The other thing to note that's very interesting is that they will typically have very high blood pressures. Okay, these APE patients, yes, will have high blood pressures, like crazy high. Like you'll be in the 280s systolic and you'll think, well, is this right? And you'll do it again because yeah, it's right. Okay, and then so someone with that sort of high blood pressure.
There's just so much pressure built up in there.
Yeah, yeah. Okay? So these are the things that I want you to know. Rails, but again, you won't be tested on this so much. There's one more thing that I really want you to know. I don't know if you... One more thing, let me just get this thing out. One more thing. That when they get to a really bad place with this APE, and if it takes you too long to get there or to be called, you may see something coming out of their mouth. And we call that, it's like foam, very good. It's called pink frothy sputum. Okay, take a note of that. That's a clinical finding that you might see. Pink frothy sputum. What?
Did we have the MI?
No, we didn't do really MIs here.
We'll have what?
You said rails and what else? What did you?
Pink what?
Pink frothy sputum. High blood pressure, hypertension.
like a pink.
Sputum?
That's also for congestive heart failure.
How do you spell frothy? F-R-O-C-H-Y.
You're right. Like crusty with a list. I better not do that now.
And that's blood? They're coughing
Yeah.
up blood?
Yeah,
it's
pretty much, yeah. It's a
With
mixture.
mucus.
Right now, it's pink frothy sputum. Let's just leave it like that.
My aunt has a Thanksgiving dish.
Yeah, it's one of the recipes.
Yeah, it looks like that, yeah.
Okay,
Another drink at a bar.
I hope we don't get invited to Europe. Alright.
Tell me the trick.
I'm not going to go into many or much of these. I want to talk about carbon monoxide for a minute. Okay? So what's the problem with carbon monoxide? This is stuff you really need to know. What's the problem with carbon monoxide? All right?
High levels of carbon.
It was a rhetoric question.
Yes, the 4 times.
You're waiting for an answer.
Hemoglobin carries the oxygen around the body. In which part of the blood? Where's the hemoglobin?
Red blood.
Red blood cells, right? Now, if the hemoglobin has a choice of, would you like to carry carbon monoxide or would you like to carry oxygen? For whatever reason, this is how Kadosh Baruch Hu made the hemoglobin. It loves carbon monoxide. It loves it so much, it'll throw off oxygen to get more. It loves it. Okay, and we say in medicine we say has a greater affinity. That's the official word. Okay? But it loves the stuff. Can't get enough of it. So this is why, if you want to end it all, you go into the garage, shut the door and the windows, run the car, open the window of the car, and very, very quietly go wherever people go. All right?
Hold on, go slower, so the windows are up.
No. Car windows are down. Car window, you taking notes?
Yeah.
Car windows are
You
down.
might miss a few classes now.
Garage windows closed. Very good.
Make a slide.
There is a fast way. You can use a hose
To put it in
attach it
there.
right to the exhaust, put it
Is
in the
this
window.
that
It's not in the book. That's
Just a quicker way to do it. Yeah.
I just want to state.
Dr. Kaborki.
Okay. So So what happens? The carbon monoxide jumps on the hemoglobin train and will be circulated around the body. Now the problem with carbon monoxide is that the cells in the tissues can't do their thing.
They don't have the same affinity as the hemoglobin.
No, they need oxygen, right? They die within how many minutes? 4 to 6 minutes, right? So they're not getting it with the carbon monoxide, right? Carbon monoxide, carbon monoxide, one oxygen. Oxygen is two cells together, two oxygens.
CO.
CO as opposed to
CO2.
as O2, right?
Carbon monoxide.
Monoxide, one.
CO, right? That's CO.
CO is carbon monoxide, yeah.
O2 and
CO2 is carbon dioxide. O2 is oxygen.
and H2O.
Oh, yeah. Alright. So, listen, this is what I want to say. But we do get carbon monoxide poisoning calls. Right? I'll tell you of one
Fire.
that was not a suicide, it was not a fire. Okay?
Boiler.
It was, well, they happen in boiler rooms, alright?
Cabin filters in your car.
Well, first of all, let me say about carbon monoxide. If you ever walk into a house and more than one person is unresponsive, get out. Just get out. Okay? If you ever walk into a house or a basement or a whatever, and more than one person you see laying unresponsive, get out. Because it's highly probable that there is a carbon monoxide leak in that house somewhere, and that has made them all pass out. You'll be next.
How long do you have?
What about
Door
negligence?
open, I mean, it's still a problem?
Get out.
How long do
Get
you
out, get fire department to test it. Okay?
You
Next.
guys don't have testers?
Guys, yeah, there are testers and all that good stuff, but it's not really gonna help you. You don't have the suits and everything that you need. Next, let me just tell you of a case that I had within, let's say, the last 12 months of people moving from one warehouse to another. Because they were leaving their warehouse, they were using all those little high-low trucks. What are they called? Forklifts, right?
Gas
And they were using them, they're gas powered, they have a combustion engine, and they were using 3 or 4 at the same time in the deepest crevice of this underground warehouse, loading, unloading place. And usually the most they'd ever have running around would be 1. But because they were moving all the pallets and everything out of this warehouse into a truck to go elsewhere, they had 3 or 4 running. I got a phone call, and I knew exactly what it was. Okay, I was about 100 miles away, and I told them, you need to all get out of the warehouse. That's number 1. Get out. Just get out, go sit down, and they were dizzy, they had headaches, some of them were really weak. So these are all signs and symptoms and things that you'll see. If it gets worse and worse, the skin will get very red, like cherry red colored skin, but that's usually a really late sign. It was a ventilated warehouse. There were big doors at street level, but because of the way it went inside, that all the way in there wasn't too much ventilation. And they never ran 3 or 4 of these little high-lows at the same time. Got them all out, got them all tested, one thing or another, gave them oxygen, all of them on oxygen, to try to push off that. And it takes a long time. After a couple hours, one of them I transported to the hospital because I don't remember. There was so many, there were like 4 patients. One of them was still just not right, just really weak, still showing all the signs and symptoms, and I transported the patient and they were monitored overnight and then released. They did the same thing as me. But they had a lab, so they could draw blood, get a real reading based on the blood of the CO levels. So you do get these, these calls every so often. You have to be aware, you have to know about
Babies
it.
are very cranky, you know?
What?
I was told babies will be very cranky. Kids and babies
Well,
will
they-
just be crying.
They'll go unresponsive quicker.
No, if it's, because they'll feel it first,
Yeah.
and if
Well,
so you come to a house and the people saying they're dizzy and they can't quiet their kids down. Get them out. I always had that.
We did most of these. We did all of these. Position of comfort, minimize movement, calm, listen lung sounds, violence, oxygen.
Doesn't ascend.
Well, I'm going to my house when I
You have to have it.
Let me just finish.
Fire.
Albuterol, which we'll speak about. All right, let's hit pause. Oxygen and airway management. So this, I usually do this lecture before you get the demo that you had last night. For some reason, like I say, the office flipped the skill night with the lecture. Usually I do this first, and then we do the skill afterwards. All right, so you did it first, no problem. Okay, this is some review. There are two ways to open a patient's airway. One for an atraumatic, what does that mean?
Trauma.
Non-traumatic patient, atraumatic, and one for a traumatic patient, okay? Remember which is which, remember when we do what. If we have a patient that was involved, or we suspect that they were involved in a trauma, we will use the modified jaw thrust maneuver, okay? Also known as the jaw thrust. If they are atraumatic, or we assume that they are atraumatic, then we will do the head tilt chin lift. Remember that. Remember, two ways to open an airway. Which one you would use for which patient. All right. Let's talk about some of the equipment. You should have been introduced to it last night. I will just talk about it briefly.
Question, if the person's atraumatic, why would you not be using the jaw thrust?
Because the head tilt chin lift is superior. It's a better way to keep the airway open for longer.
Yeah, but don't you have the
Easier to
issue of
use.
Yeah, but don't you have the issue of worrying about the tongue though?
It will deal with the tongue when you
And not
insert an airway. Okay?
Only if you.
Alright? So let's talk about our, what we call airways. This is what EMTs carry. They come two styles. OPA, oropharyngeal airway, and NPA, nasopharyngeal airway. So from the name alone, we understand that the oropharyngeal airway will be placed in the mouth. Very good. And it is a hard plastic thing. Some of them are hollow in the middle so that it can help to get the oxygen through. And it is shaped specifically to keep the tongue out of the larynx. All right, that is the whole purpose of the OPA. It is for airway. It has nothing to do with breathing. You have to be able to split off airway now. Okay, airway is keeping the space and the pathway open from outside to the lungs, getting air inside. That is airway. So OPA can be used on any patient as long as they don't have a gag reflex, okay? Which means you insert it, they gag, you
Take it out.
pull it out. That's it.
Anatomically.
Anatomically. Okay, so how do we insert it? How do you teach you to insert it?
There's two ways.
Two ways. You can do it at 180 degrees, go up along the soft palate, and then turn it 180 degrees, or you can just go in at 90 degrees and turn it whatever. Either way, the flange,
Which one would you recommend?
it doesn't matter, whatever you prefer. Either way, the flange should sit on the lips, okay? And remember, this patient doesn't have a gag reflex, therefore is most probably unresponsive, okay? In our AVPU scale, they're probably hitting the U. If they do respond to this, then they're most probably a P. They're not a U, a true U, okay? So truly unresponsive will not respond to this either. And you're able to use your BVM way more effectively because you have inserted the OPA, alright? So again, who can get this? Any patient can get this. Contraindication is gag reflex. You remove it, you don't try again. How do we measure this? There are two ways to measure. You need to know both methods. How?
Middle of mouth to thing?
Center of the mouth to the angle of the jaw, or corner of the mouth to the earlobe. Good.
And center of the mouth to where?
The angle of the jaw.
Or corner of the mouth, which is what I usually use. If I'm measuring one, I do corner to the earlobe. They're easier to see. Okay, this guy is called an NPA, stands for a nasopharyngeal airway, and this will be placed in the nose. Okay, did he talk about which nair is better?
Yeah, left.
Right.
Right.
Right is bigger, right?
Right.
Right's bigger.
Right is better.
And go to the left.
No.
the bevel on the sternum.
Right, so go
Okay,
to the right.
very good. The bevel points towards the sternum of the nose. Very good. You need to use a non-oil-based lubricant. They usually come with them, these little packages that you can smear on that. And that's get inserted. Now, who can and cannot get an NPA? Right, so everybody can get an NPA. There's no gag reflex with this. However, there is a New York State protocol that says if you suspect a head trauma, that this should not be inserted.
There's also
The brain might be herniated.
Yeah. Yeah, I mean, you can put in two if you can get one in the other there
Put two on the
also.
same one.
to 6,
Okay? So, this is your airways, okay? So when we say insert an airway, we're referring to either an OPA or an MPA. Good. Suction. No picture of the machine. Suction can be handheld, manual suction, or it can be mechanical, electrical suction. Alright? This is very rarely used by EMTs. This is called a French catheter. This is for doing sterile suction, deep suction. I don't think EMTs use this. Okay, a French tip. This is what EMTs use. It's known as a Yankauer. It's a hard plastic tip that's attached to tubing that's attached to your suction. Did he show these to you?
Yes.
He did. Okay, good. Let's talk about the rules of suctioning. Because this is something that they're really into. Okay, on tests and things, really big time into the rules of suctioning.
as you can see.
How far can you go in?
As far as you can see.
As far as you can see. When do you suction?
When there's liquid.
On the way out.
On the way
A
out.
circular motion.
Circular motion for up to.
15 seconds.
Okay, but on
What do
the
you mean
way
on the way,
out.
on the way pulling?
Meaning, you go in with the suction not working.
And you cover the hole.
You see, then you cover the hole, you make the suction, fill the circuit, make the suction work, and circular motion on the way out is the way you suction. Okay?
What's the time?
15 seconds max. Okay, they showed you oxygen cylinders.
15 seconds isn't 6 seconds for a child?
E-tank, I think. That's,
And that's 15 seconds per sweep.
Definitely.
Yeah, then you oxygenate again,
Yeah, the D, right?
and then you can go again.
No, the E.
Alright, let's talk about oxygen cylinders quickly. Cylinders, tanks, same thing. They have. Are we good?
Yeah. We good? I think we good.
Yeah.
I was under strict instructions not to ask any questions, not be that guy that's gonna keep us till 12 tonight, because I have no idea what you're talking about.
You'll take
But
the
I'm listening to
classes.
everybody. What?
You'll take the 4-hour class.
No, keep going, keep going. And don't let me hold you up, guys. So I just want to explain why you shouldn't hold me up, because
He's gonna hold us up,
What's your
explaining why he's
question?
not holding us up.
what's this for? Someone that is unconscious?
Oh, what suction?
This is
Suction is, oh, you wanted that last night.
oxygen.
Anybody that has fluid in their airway that you need to remove.
Like vomitus.
In the airway, they can't
Well, that's fluid,
47.
And then after they can't breathe.
okay? Right, oxygen cylinders, oxygen. Oxygen cylinders in the old days were all green. In the United States of America, they had to be green, completely. It's interesting because in South Africa, they have a black and silver or black and white tank. And it's very interesting. I thought it was green like everywhere in the world. Apparently not. So, in the United States, they all have to be green. They used to be made of iron, and they were completely green. They were extremely heavy. Now we have this sort of aluminum, sort of lighter metal, whatever it is exactly. And they're green just on the top, and most of the tank is actually silver. Okay, but there is still the green, as you see all the different sizes. What must you know? You must know about the PIN index safety system. I'm sure that he showed that to you. The concept or the reason behind it is that other people, other than in medicine, use oxygen. Okay? We use something called medical grade oxygen, which has passed. It's a drug. It's in the USP, the United States Pharmacopoeia. That's a large book that lists all the drugs. So oxygen is a drug. And the PISS system is in order that only our regulators will fit onto our oxygen tanks. So if you have a welder's tank, our regulator will not fit. Okay, and that's what the PIN index safety system is there to do, to protect you from getting the wrong sort of oxygen or the wrong sort of tank. Test question all the time, full cylinder, I would say 2,000 to 2,200 PSI. We measure the amount of pressure in a tank in PSI, which is pounds per square inch. It's an old-fashioned measurement. Very few things in medicine that we don't use metric and the new, way. This is one of the
Well,
things.
gases are always measured in PSI, no?
No, there's got to be a metric version of PSI that they could use
thin
today.
ones, they're not.
Oh, no?
Yeah.
Okay? In general, in medicine, everything we've changed, we use everything in metric. Everything. We used to talk about grains of medication and different, old stuff. But now everything is milliliters and milligrams and micrograms, and so here we're still using pounds and inches. So
You ask the patient how many stone he weighs?
you could. They want to know what you're talking about. But, all right. And if they answered you, you wouldn't know how many pounds that was either. By the way, all pounds now in medicine have to be converted into kilograms. We don't use kilograms with the general public because nobody knows anything about, kilograms or how many kilograms they are or anything like that. We don't expect them to. You're expected to be able to convert it.
I guess that's for another later date.
Medic school, when you have to do math and stuff, conversions. Here's your PIN index safety system. It'll be in there. It'll be 3 protruding pins. Thank you. And I'm sure you saw that. Did he show this to you last night? Yeah. Okay. Good. So you got to see it.
Shaggy, he said to you.
It was attached there with the screw with the 3 pins. This is your pressure gauge. This is where you'll read your 2,000 or your 2,200. Okay? And this is the flow meter. Now, we provide oxygen to our patients in LPM, liters per minute. Okay, again, liters per minute is how much we are giving to our patient. So we may be giving 15 liters per minute, That's it. That we forget about the pounds per square inch at this point. Okay, that's just this number is in the PSI. After that, we go to liters per minute, and this dial will give us the flow, how much we're actually getting. All this you will practice with. You'll learn how to use this. Okay? Let's talk about some of the delivery devices. Oh,
It's not a
something I
catheter
wanted to
shot.
add to this slide. Can we pause a minute?
Editing now.
Just pause. Not switch. So, the non-rebreather mask. The non-rebreather mask is the mask that you will use the most often. This is the mask that you will use on most of your patients. Okay? Anybody who is breathing adequately will get a non-rebreather mask. Okay? So I want to cross out this word.
Which one? On the breathing.
There's an animation for that.
Yeah. We'll do that soon.
That's the exit.
Okay?
You can just
Only to use on breathing adequate.
People who are breathing adequately, okay, get the non-rebreather mask, which is going to be most of your patients, okay, most, right? Now, these are things that you must know. I would just say 15 liters per minute, that's the flow rate, and this delivers 90% oxygen. Okay, did he show you the different parts of the mask?
Yes.
The reservoir, how to fill it, the tubing, and the mask, right? You will get chance
Make sure you
to,
fill the reservoir before you do anything.
all of it.
you'll get chance to do hands-on and to get to know it, all right? The reservoir should be about 1/3 to 2/3 full. And when is it used? On which patients? Adequate breathing. Very good. Nasal cannula. Now, nasal cannula is a problem really because I'm using it more and more and more than I ever did, okay? And EMTs are not really supposed to use it. So let's talk about, according to New York State, when you're allowed to use a nasal cannula, okay? Really, there are only two conditions that you're allowed to use the nasal cannula. Only two, okay? Even though you carry it, it's in your bag, it's on your ambulance,
Gag reflex.
you don't use it only in two special circumstances, all right? Number one, you had a patient, maybe having chest pain or whatever it is, can't breathe. And you give them the non-rebreather mask, which is very good, and you set it to 15 liters, and you're giving them how much percent? 90%. All of a sudden, they start ripping it off their face. They tell you they can't stand it. They don't like the smell. They don't like the rubbery thing over their nose and mouth. They feel claustrophobic. It doesn't matter what they tell you. They just can't stand it. What we call that is they won't tolerate the mask. Your job is to keep them calm and explain to them how really great the non-rebreather mask is and how, you know, your oxygen may be depleted and we really need to give you as much oxygen as possible. The best way to do it is using the non-rebreather mask.
Big tube instead, or we have to put this up your nose. That usually works.
No, that's not something that you should be doing. No. But I will tell you a story later.
That would work.
What
for
I
me.
did
I'll
once.
keep the mask, thank you.
I will tell you, remind me, I'll tell you a story later. Now, this patient continues to be in much distress and discomfort due to your non-rebreather mask. And you know that one of the things you're going to learn about an MI, for example, a heart attack, is you don't want to give them any more stress and discomfort than they're already in. And even the respiratory stuff that we did earlier tonight, we said keep them calm, right? So if now you're making them more anxious, right, or uneasy, you're not doing any good. So here is situation number one. You can remove the non-rebreather and replace it with this nasal cannula. Nasal cannula, hopefully he showed it to you last night, has just two prongs that go into the nose, goes around the ears, tightens under the chin, and gets plugged into the oxygen. The problem is that in New York State, you can only set it up to 6 liters per minute. Don't be surprised if me or one of the medics that I deal with or teach or taught will tell you crank that up to 15. Okay? You're going to be taught that no, you can never go over 6. So I'm not teaching you that. I'm teaching you that according to New York State protocol, the max you can use a nasal cannula is 6 liters per minute.
Why is that?
Unless
Smaller passages?
Unless you're told to go more, and don't be shocked. That's what I want you to understand. Okay, because that's what I'm doing now, a lot. Okay? I'm doing it a lot. So,
Second reason.
the second reason for using this very good. Second reason is like this. You come into the apartment or to the house, and you see a patient who is wearing a nasal cannula. They're on home O2. Now, who is on home O2? Do you know which patients are on home O2? Emphysema, COPD is very good. They're on home O2.
But it's like a drip, it's very little.
Well, it's not a drip because it's not a
It's not
liquid.
medical.
I'm dripping.
It's on a very low rate. It'll be on 1 or 2.
Right.
Okay. Question you need to ask yourself and the patient, why did they call? Did they call because they cut themselves chopping an onion? Okay? Which, what I mean by that is, did they call because they have no difficulty breathing any worse than the usual? In which case, you can take them off of theirs, put them onto yours, and transport them with nasal cannula. Okay?
Why can't they just have it
However, here's the caveat to that statement. If they called because they can't breathe or they're having difficulty breathing,
It's obviously not working.
you right away, you understand it's not working,
Look
you
at
right
oxygen.
away switch them over to
Non-rebreathing.
non-rebreathing.
Or switch the oxygen.
Or make sure the oxygen. They don't have tanks, they have machines in the house that produce oxygen from room air. Certainly not as good as our tanks.
So even
okay?
your nasal cannula is better than what they have in their house?
Yes.
What is
When hooked up to your oxygen.
No, but here's the question. If
The
they
nasal
had a cut in
cannula is the
their,
same.
if they had a cut in their finger and you're transporting them, why do you need to transfer them from their nasal cannula? Because their breathing is not an issue.
Right.
So then why do you have to? Why are you saying transfer them from their nasal cannula to yours?
Because you can't take their machine is like the size of this system.
Oh, it's not a transportable.
No.
Oh.
So you take theirs off,
But you're,
and also you want to make sure, guys, listen up, because he asked a good question. Well, I'm going to expand it. Why take theirs off and put on yours when you could just detach theirs from their machine and put it into your oxygen?
There's a
I'm going
clog
to
in
change your question.
There's a clog in it too.
Theirs, they need back in their house when they get home. Now, if they take it to the hospital,
They ain't getting it back.
they may not get it back. Okay? Because everything in the hospital belongs to the hospital. Okay?
Including the patients.
Yeah, so they may not get that back. So you want to leave that at home. You've got these anyway. You're not paying for them. The other reason is that they have them, sometimes they're like 100 foot long, right? They can walk to all rooms of their apartment. They can get everywhere with it. You don't want to be schlepping that around. Okay, yours is like 3-4 foot long, right? You don't need that whole long thing. So leave theirs there, change it to yours, and go with that. All right? Patient must be breathing spontaneously. I'll agree with that. What does it give? So 6 liters gives 44%.
15, I'm assuming it gives it 90.
That's right.
What did you say?
Doesn't matter. 6 liters gives 44%. You need to know these numbers. Guys, okay, focus. Focus, not that late. Come on. Okay, 15 liters on this will give 90%. You got this? You understand these two masks?
Those numbers are proportionate.
It's proportionate.
No.
Just remember.
Happens to be.
12 is
I
88.
mean, it's also proportionate.
Alright, this is a Venturi mask. You do not carry Venturi masks on your ambulance. They were approved for New York State EMTs. Where you'll see these? You'll see these in nursing homes, and you may have to transport a patient that is on a Venturi mask.
What is the difference between that?
Okay, so each one of these colors
It's like a nebulizer.
has, each one of these colors will allow for a specific percentage of oxygen that was prescribed for the patient. Okay, so if the patient needs, 22% oxygen or some wacky number, one of these will fit the exact order that the doctor gave. Usually they're put on by pulmonologists that deal with this stuff, and that's what they want the patient at. So just transport them on the Venturi mask.
Isn't there an also, it says that there also, but it's also attached to a water source, so it's it's not just oxygen.
It doesn't have to be. It could be humidified. You can humidify any oxygen in your ambulance by putting a special humidifying bottle into the system. You can only do it on the ambulance ones. You can't do it on the portable tanks.
But with a portable tank, you can do it on this one. If you had,
No, only probably with their own oxygen system. You don't need to worry about it. Okay? Tracheostomy mask. Let's talk about that. Okay? Tracheostomy mask. Some people have had such disease or problem or whatever it is, whether it was congenital or whether it was the smoking, whatever lady, that they lost their larynx and their voice box and basically lost the ability to have an airway from outside here to inside the lungs. What happens is that a tracheostomy is performed and a cut is made through the skin, through the neck, right into the trachea, and a special plastic piece is inserted, and it's called a stoma. You need to know this, and then you need to know what to do. Again, I've seen this on state questions. A stoma. All right? And the first thing you need to know is if you're going to ventilate somebody through the stoma, let's say in cardiac arrest, you need to close the mouth and nose. That's the first thing you need to remember.
The tracheostomy mask is called a stoma?
Yes. But you need to close the mouth and nose. Why? Because as you ventilate through there, okay, over half of it's going to go out through the mouth and nose. So you need to close the mouth and nose. They usually have a mask, special mask that clips onto the stoma. They usually have one. If not, yes, you can use a non-rebreather, a pediatric non-rebreather that will fit over it. Okay?
So how do you close the mouth and the nose?
With manually.
So someone walking in, to them it would look like you're trying to
Kill them?
Kill them.
Well, you'll see that you're actually
breathing into their stomach.
You're actually bagging them. I'll show you in a minute. Okay? Alright, nebulizer. Did he show this to you last night?
Yes.
Alright, so as far as you're concerned, EMTs. Shraga, you saw this last night?
Yeah, it was amazing.
Good.
He didn't use the drug.
He didn't use water. He used water.
I see.
Yeah.
we got albuterol. We got the real stuff.
I know.
We had a lot of
I took a hit. It was great.
So stoma
Expired.
is any opening, an artificial
Expired
stoma.
doesn't mean anything.
Right, but the one
can't
that
use
we talked
expired.
about in EMT
Use
school
expired.
is the
You
tracheostomy.
can't use it as an EMT, I'm saying.
Alright, guys, focus. We're almost there.
Officially.
I don't know that.
It's something to do with flow.
Nebulizer. EMTs were granted permission a number of years ago to use a drug known as albuterol. I will talk more about the drug when I do a pharmacology lecture a little bit later on. However, it is used in this device, okay? And it has many parts. It has this chamber here, which is the nebulizer. It has tubing, and it has a mask. The mask sometimes is changed for a pipe. And if it's an older person, they can actually suck on the pipe and hold it in and try to get the medication into their lungs, all right? Use it 4 to 6 liters. I'm okay with that. I prefer to say enough that you see a mist coming out of it. If you try to put 15 liters into there, you will blow it, okay? The whole pipe will come off and it will blow. There isn't enough room in there to take that much pressure. So 4 to 6 liters, again, I start at 4. If I see a mist, I'm good. If not, I up it a little bit. It's very easy to do. You put this on and you have them breathe normally.
That you use when there's when
Asthmatics,
asthmatic.
COPDs, all right? We'll get
Who's
to
wheezing?
30
No?
minutes?
Wheezing, yeah.
When's wheezing?
30 minutes, or you transport within the...
No. This should take about 5 minutes to do it.
Is that
5 to 15,
Yeah.
and you transport while this is going
And
on.
you can only
Only
do
2 rounds.
and you can only do right 2 rounds in.
We'll talk about the drugs
Oh, okay.
on another night. This is about the equipment.
For the tracheostomy mask, I read it. What's the flow? What should that be on?
Oh, it depends what you're doing. Are you using this with it? Usually you'd be using
that's
this.
the piece that attaches to something.
Yeah. So if you're using this, you'll take off the mask and you'll plug that right into it.
You're still using 15?
Yeah,
Okay.
What's the 15?
15 liters. All right, let's talk about this. Did he teach you the EC clamp last night?
No, C-clamp by CPR.
No.
No, we didn't get a seat.
No?
No.
EC.
No.
Oh, EC, no.
Okay, we'll do it then. Okay, we'll practice with this. This everybody has to learn how to use. It's called a BVM. When is this used?
Inadequate.
For inadequate breathing. All right. What's the definition of inadequate breathing? So
Not breathing back.
not breathing at all, right? That's inadequate. Okay. What about if someone's breathing 4 times a minute? Is that adequate? What did I say normal breathing is for an adult tonight? 12 to 20. So 4 times a minute, inadequate, right? So anything that when you look at them and you say, wow, he's not going to be perfusing properly, he's not breathing properly, whatever, even if he's alive, even if he's breathing on his own, but that's why I like the word inadequate.
Well, is there a measurement that below?
Yeah, officially it's below 8. Because it rhymes. Below 8, ventilate.
Is there
That's
why
why
equipment?
I teach the medics below 8, intubate.
Oh, that's not the scientific reason.
No. And I don't like using 8. Honestly, I have major problems with it, and I don't do it unless it's like 4. But for the tests and everything, 8. 8 or less, ventilate.
Is there equipment for when they're breathing too fast?
Yeah, this. Very rarely you'd need it. Very rarely you'd actually do it.
So let's say they're breathing 30 times a minute.
30's fine. I'm talking about 80 times a minute.
When we called outside for my 2-year-old because he was breathing so fast in the middle of the night.
How fast? 30 for a
We didn't know.
2-year-old's
He was
normal.
breathing 60 times.
Okay.
But they
Okay.
said up to, or 50 times a minute. The doctor said up to 60 is okay.
Yeah. The smaller you are, the faster you can go. Heart, breathing.
So what would this do for someone that's breathing
You would,
quickly?
well, what's happening, so let's say that person was, let's say 80, right? And they're breathing 60 times a minute. So you have to understand the pathophysiology, what's going on. What's going on? They're just not getting air in, all the way in, causing the diffusion and CO2 leaving. It's just not happening. So basically they're getting a buildup of CO2. All right? It's going to get higher and higher and higher and causing all sorts of problems. With that being said, what you can do with this is you can bag them once every 6 seconds, okay, and cause a proper ventilation. Air in, air out. Okay? So that's what you'll ignore their 60 times type of thing, and you'll just do 1 every 6 seconds.
Override it?
Yeah.
Well, it's also giving them a higher concentration of
Yeah.
oxygen, which is every breath they take in will now be more efficient. You missed it. You missed it. Oh, do it again. Do it again.
Gotta do the typewriter.
Okay, numbers. You can use a BVM on room air. You can use a BVM on room air. New York State will mandate that you use the BVM on room air when you arrive at the scene. So you arrive at the scene, you see the patient's apneic, or you're being told that they're apneic, you look, you right away take out your BVM, start pump bagging, we say, bagging, okay, bag valve mask. Start bagging. That is what New York State's going to want you to do. We'll get to that later on in the course. So on room air, how much oxygen is in ambient air? We know. 21%. So is that good? How much do we need to breathe?
60. Oh no, we breathe.
21%.
About 5.
Yeah.
Why? How do I know that?
Oh, it's a 16.
Because we release 16% out.
Very good. 21 in ambient air, 16 when we breathe out. That means we used 5%. So we're giving them 21% with the BVM without oxygen. It's not bad. It's not bad, right? It's a good start. So, when we attach it to 15 liters, we're going to get close to 100% oxygen delivered.
That's
Okay?
with reservoir.
Yeah, which is, will always.
What is the reservoir doing that it adds so much percentage to the oxygen?
Well, it's always got a flow of oxygen. There's never a time when there won't be oxygen.
Even between pumps.
Yeah, yeah.
But you know what?
It's going up from 50 to 60 all the way to 90.
Yeah.
That's
So that's what they're going to ask you. They're going to want you to know on room air, and they're going to want you to know on
What do you mean by room
15
air?
liters of oxygen.
What do you
Okay?
mean by- what do you mean by room air?
Now, what?
What do you mean by room air?
If you're just using the
Room
hand
air without attaching it to oxygen.
Okay.
Now, something you need to know. The state does not like the BVM to be used by one rescuer. We are teaching you how to use it as a single rescuer. We will teach you how to do it. We'll make sure you know how to do it. But the state does not really approve of it. Okay? State says that it's better to take your pocket face mask and attach it to oxygen and blow air into the patient through the pocket face mask, like the one we gave you at the beginning. That's better if you're on your own than using a BVM.
Why? Because you can have more control.
The problem with a BVM, these are all test questions, everything I'm saying, by the way. The problem with a BVM is that it's very difficult to maintain the seal. And if you're on your own, you gotta maintain the seal, hold the airway open, get the air in. Okay? It's difficult. So the state prefers that you have 2 rescuers using a BVM. I can tell you honestly that most of the time you'll be doing it on your own. You better know how to do it on your own.
See ya.